All right. Hi, everyone. So we will get started here kind of slowly, just as we let people kind of in through the waiting room. But I'm Dr. Casey Lockhurst. I'm one of the surgeons at Mass General. I'm also the co-director of the Inpatient Pancreatitis Center at MGH. So really excited to have our second session of the Pancreas Academy this week. And we are joined here by Dr. Michelle Saad and Dr. Naylor Brownell, who are, wonderful in the pediatric GI world. And they're going to be speaking to us about some topics here today. So just a reminder, if you guys have any questions, please feel free to put them in the chat. We'll have 20 minutes of talking by them, and then we'll follow that up with any questions. So please pop anything in there, and I'm happy to read it out. But to start, I'd like to introduce Dr. Saad. She's a pediatric gastroenterologist at Cincinnati Children's. She focuses on pancreatic disease, such as pancreatitis and exocrine pancreatic insufficiency. And she's committed to improving the diagnosis and treatment of pancreatic conditions in children, ensuring that they receive comprehensive and passionate care. And Michelle, welcome. Thank you so much for joining us today.
Thank you, Casey. I appreciate the warm introduction. And thanks to CAPER for the opportunity to present today on this topic. Let me share my slides real quick. All right, perfect. So today's, I was asked to present on pediatric acute and chronic pancreatitis. I'll be talking about etiologies and management. The two lectures are meant to be complementary. So Dr. Brownell will talk also regarding chronic pancreatitis, and we'll discuss some things more in details in his part of the lecture regarding that. So my goals today are to help understand the epidemiology of acute and chronic pancreatitis in children. We're going to review definitions and common etiologies, identify diagnostic approaches, discuss severity scoring in AP, and outline some treatment strategies and modalities that we have available. We're also going to discuss the management principles for chronic pancreatitis and explore some current research and future directions in the field. So the reported incidence has increased lately over the past couple of decades, likely due to the greater recognition that we have in children, especially with clearer diagnostic criteria that we'll talk about. For acute pancreatitis, the current incidence is between 3 to 13 per 100,000 per year, whereas for chronic pancreatitis, we're looking more so towards 0.5 to 2 per 100,000 per year. Usually, acute pancreatitis affects children of all ages, but peaks in adolescence, whereas chronic pancreatitis typically affects school-age children, as well as adolescents with a median of 12 years. We have a slight female predominance in both acute pancreatitis and chronic pancreatitis in pediatric patients. We're looking more so around 57% female compared to male. So in terms of definitions, and this is going to be an important slide moving forward, for acute pancreatitis, we require 2 out of 3 criteria. So we need abdominal pain that's suggestive of or compatible with acute pancreatitis, so pain that's acute in onset in the epigastric area, sometimes can be radiating to the back, serum amylase and or lipase more than 3 times the upper limit of normal, imaging findings that are characteristic of or compatible with acute pancreatitis. Whereas when we're looking at acute recurrent pancreatitis, we need 2 distinct episodes with complete resolution of pain in between, usually around more than 1 month of pain-free interval, between both episodes, or we have complete normalization of serum pancreatic enzyme levels in between. For chronic pancreatitis, we're looking at always imaging findings that are compatible with chronic pancreatitis, plus either abdominal pain that's consistent with pancreatic origin, exocrine insufficiency, or endocrine insufficiency. Or if we have a surgical or pancreatic biopsy specimen that's compatible, that also can help diagnose the patient with chronic pancreatitis. In this slide, I've combined the etiologies for both acute recurrent, and chronic. We're mostly in 60 to 70% of recurrent episodes looking at genetic etiologies, mostly PRSS1, SPINK1, CFTR mutations. Biliary etiologies are common. Gallstone pancreatitis can be a cause of acute pancreatitis. If the gallbladder is not taken out, we tend to also see some recurrence there. Choledochal cyst, pancreas tabesum are also major etiologies that can be contributing. Drugs should be on your differential as well when looking at patients who have multiple episodes, especially valproic acid, PEG asparaginase, metabolic causes, checking your triglyceride levels in patients with acute pancreatitis. Hypercalcemia can be another etiology as well. Infections are some of the major causes of pediatric acute pancreatitis. In some patients, we may consider autoimmune etiologies. We can check IgG subclasses for potential IgG4-related autoimmune pancreatitis. Also, although in terms of AIP, that's less frequently seen in children compared to patients who have normal IgG4 levels. Trauma is a cause, definitely. If you have blunt abdominal trauma, a patient can develop acute pancreatitis afterwards. Post-ERCP pancreatitis can be seen in up to 12% of patients who undergo ERCP. And our idiopathic bucket is slowly getting smaller and smaller as we understand other etiologies a little bit better, especially the genetic and hereditary component. In terms of diagnosis, we mostly focus on really those definitions that we've shown in the prior table. However, we need to be mindful of clinical symptoms. Those include acute abdominal pain, nausea, vomiting, anorexia. In chronic pancreatitis, we can have steatorrhea, growth failure, bloating symptoms, diarrhea that can happen. Lab testing, you can consider serum amylase and lipase in the acute phase, liver enzymes as well to see if there's any biliary component there. For chronic pancreatitis, we start talking about fat-soluble vitamins, testing for endocrine insufficiency, pancreatic function testing, which can be direct or indirect, and that will be elaborated on more in the next talk. Then we have imaging that can help you make the diagnosis as well. Starting point is always an ultrasound. However, if a patient has recurrent episodes, we want to consider getting an MRCP, which is magnetic resonance cholangiopancreatography, that helps us see the pancreatic ducts, biliary tree a little bit better, especially when we give IV secretin and IV contrast as well. And then genetic testing is done routinely in all of our patients who have recurrent episodes because we are seeing more and more patients who have genetic etiologies behind their recurrent episodes of pancreatitis. In terms of severity of acute pancreatitis, this is the classification that was done by the NASPGHAN Pancreas Committee, which is the North American Society of Pediatric GI, Hepatology, and Nutrition. So once we diagnose a patient with acute pancreatitis, we look to see if there's any organ dysfunction. And if so, is it present for more than 48 hours? Mostly, is the patient hypotensive despite needing more than 40 ml per kilo of resuscitation? Are they anuric? Do they have a creatinine that is twice the upper limit of normal? Are they needing respiratory support? And if so, if it is going on for more than 48 hours, then that would fall under severe acute pancreatitis. If less than 48 hours, then that's moderately severe. But patients can also qualify as moderately severe, especially if they have any exacerbations of local pancreatic or systemic complications or any exacerbations of prior comorbidities that they also have. In terms of severity as well of acute pancreatitis or scoring severity, so I have a patient who comes in, they have acute pancreatitis. How do I know which bucket they're going to fall into? Are they going to have a mild course? Are they going to end up with a more severe course? There's been multiple markers that have been looked at. I'll identify some of them here in this slide. So BUN, or blood urea and nitrogen, has been studied by Dr. Vitale and the team in 118 patients. This was a prospective analysis, and they found that BUN can be a predictor of severe acute pancreatitis with an area under the curve of 0.75. Another study regarding cytokine profiles was a prospective enrollment for 4 years duration. We checked cytokine profiles within 48 hours of admission, and the study found that interleukin-6 and MCP1 help differentiate mild from severe forms. CRP is also of immense value in helping predict severity of children with acute pancreatitis, specifically a cutoff of 10.7 milligrams per deciliter for the CRP. Increases the sensitivity to 91% and specificity to about 84% in having a severe course. This is a validation study with figures on the right side of the slide that you're seeing, where we can see that when we combine the BUN in green along with albumin, we end up with a model that helps predict severity better with an area under the curve of 0.83. So BUN and albumin can be of predictive value for children with acute pancreatitis in terms of severity, and so is the CRP. In regards to management of acute pancreatitis, we need to focus on fluid resuscitation, pain control, electrolyte correction. If we're thinking that we have a drug that's inciting the episode of acute pancreatitis, then we stop the offending agent. But talking about fluids and focusing on that a little bit more, What type of fluids and what rate, that has been a debate for quite a while, but here's what we know so far. There's been a study by Dr. Farrell et al. That looked at the use of lactated drinkers compared with normal saline, and found in that retrospective FIS study that patients who were administered lactated drinkers had a shorter stay and had a lower cost of hospitalization. This was further studied through a multi-center randomized controlled trial, where they also found a higher proportion of patients on LR that were discharged before 72 hours. And then we have the waterfall study regarding aggressive or moderate fluid resuscitation. This was done in adults. It's a multi-center study. About 18 different centers were involved. The aggressive fluid resuscitation was about 3 ml per kilo per hour after initial bolus fluid administration, and then the moderate was about 1.5 ml per kilo per hour administration. The trial was actually halted because they saw a difference in safety outcomes between the two groups in terms of more patients having fluid overload in the aggressive category compared to the moderate, without a difference in the incidence between moderately severe or severe pancreatitis. And then Dr. Nick Norris and team recently published a study regarding liberal fluid resuscitation in pediatric acute pancreatitis. By liberal, the definition in their study was above 1.5 times maintenance versus a conservative approach of less than 1.5 maintenance. And what they found is that there was a reduced rate of ICU admissions in the liberal fluid resuscitation, lower rates of moderate to severe disease, and even patients who got about 2 times maintenance fluid had no increased risk of organ dysfunction or severe disease in the study. And mind you, this was only within the first 24 hours, of the hospitalization. In terms of nutrition and management of acute pancreatitis, this is from the NASPGHAN Pancreas Committee again, where it was determined that early enteral feeding is safe and improves outcomes. Enteral is superior to parenteral nutrition. We need to avoid prolonged NPO cases unless we have severe complications for the patient. Jejunal feeds are only reserved for those who are really unable to tolerate oral feeds or nasogastric feeds. Specialized formulas are not necessary in pediatric acute pancreatitis, and a low-fat diet doesn't really have a space in this field unless we have a patient who's significantly hypertriglyceridemic. We would not start to consider it unless we have triglyceride levels above 500, which have shown to increase the risk of acute pancreatitis or be associated with it, more so above 1,000. In terms of management, still on management, we're talking now about minimally invasive and endoscopic approaches. When to intervene. If we have a biliary etiology, we can consider an ERCP, especially if we have a common bile duct dilation or we have signs of obstruction. In a symptomatic fluid collection, we wait about 4 weeks for it to turn into an encapsulated collection where we can intervene through US-guided drainage with lumen opposing metal stents, as you can see in the picture. In some minor cases, percutaneous drainage can be considered with either ultrasound guidance or a CT, or very rarely nowadays, minimally invasive necrosectomy. In terms of the aftermath of acute pancreatitis, we used to say it's a one and done, and then we didn't really use to give a lot of patients anticipatory guidance afterwards. However, now we know that there are consequences to having acute pancreatitis. Even a single episode can predispose you to prediabetes, diabetes, and then a risk of EPI. So here's what we know in terms of pre-DM and DM. We know that it's associated with AP severity, especially if patients have risk genes, which was found in about 17% of patients at 1 year by a study by Dr. Abu Haija et al. And then there was a population database study as well that showed that 5.4% of children who had a single episode of acute pancreatitis ended up having diabetes afterwards with a median interval of 18 months. In terms of EPI, that's been mostly studied in adults as of now. We have the PAPI study by Dr. Phillips et al., where the results of the study were preliminary published. We saw that there's a 34.1% incidence at 1 year in adults of exocrine pancreatic insufficiency with a single episode of acute pancreatitis, a 3-fold increase with moderately severe or severe. And then even patients who had mild acute pancreatitis, about 12.8% of them ended up with exocrine insufficiency at 1 year. Now, shifting gears a little bit to the medical management of chronic pancreatitis. Again, this is by the NASPGHAN committee. So we need to monitor for growth, monitor pubertal development and fat-soluble vitamins, consider pancreatic enzyme replacement therapy, and that will be talked about further in the next talk. We need to screen the patients yearly for pancreatogenic diabetes mellitus with a fasting glucose, A1C, and then if we have any issues that pop up there, then you can consider an oral glucose tolerance test or potentially MMT for your patients. We follow an analgesic pain ladder, and we can consider neuromodulators. Typically, that starts with non-opioids, then weaker opioids, stronger opioids, and if really needed in these patients who are having these recurrent episodes of pancreatitis, then you can consider an inpatient hospitalization for further management. We need to counsel all of our patients, especially our teenagers, on alcohol, smoking, vaping, healthy diet, and lifestyle and its relation to pancreatitis. We need to consider endoscopic intervention when we have ductal abnormalities, and then reserve surgical management for patients with intractable pain, especially those who fail medical endoscopic therapy or have an impaired quality of life. There's also a significant psychological impact that needs to be addressed. Thereby, multidisciplinary approach is oftentimes needed for our patients. And there's always a risk of malignancy in genetic pancreatitis that I want to highlight. There's a high risk in PRSS1, moderate in SPINK1. So all of these things are important to be discussed with our patients and to keep in mind when we talk about managing those patients. In terms of endoscopic approaches for ductal or structural components, the indications are usually recurrent pancreatitis with ductal abnormalities. Some of the other indications include any obstructive lesions of the pancreatic or biliary ducts, anatomic variants that can predispose to pancreatitis, especially pancreas divizum, where some of the patients may benefit from a minor sphincterotomy during the process. Other key interventions with the ERCP can include stone extraction in biliary or pancreatic ducts causing obstruction, a sphincterotomy, as we talked about, ductal stenting for strictures, and some of these patients require serial stenting for multiple months duration in order to help relieve the obstruction or remodel the duct. EUS can also be considered and has significant diagnostic value for the evaluation of strictures, masses, ductal dilation, and it can help us obtain FNA if required in some patients as well. So in the next couple slides, I just wanted to highlight some new updates in the field and some rising research. So we have regarding CFTR modulators by the INSPIRE 2 cohort. This was a multi-center retrospective cohort study of children with both acute recurrent and chronic pancreatitis from the INSPIRE group. Patients had a CFTR variant and were on a CFTR modulator that was initiated during the period of the study. Most had CF and some had CFTR related disease. The study included about 16 patients who had 1 year follow-up in it. The patients were non-normally distributed, thereby they studied the incidence density per person per year. And you can see that in the pre-category, before the initiation of the CFTR modulator, the density was about 0.3 per person per year episodes. That decreased to 0.18, and that was statistically significant in their study. Pancreatic enzyme replacement therapy has also been studied by the INSPIRE group, and it's been shown to reduce pancreatitis frequency in children with pancreatic sufficient ARP or CP. These patients had about 2-year follow-up, and you can see in this box and whiskers plot showing significant decrease in annual incidence of acute pancreatitis before and after the initiation of pancreatic enzymes, with a notable drop from 3.1 in terms of incidence rate of AP to 0.7. And then the microbiome microbiome studies have been on the rise. What we know is that alterations in bacterial composition is seen in children with acute pancreatitis, especially in severe acute pancreatitis. We have enrichment in Enterococcus faecalis, which may drive more severe inflammation. That was a study done by Dr. DK et al. And this biosis may contribute to intestinal barrier dysfunction with increased bacterial translocation, systemic inflammation, and can actually persist at 3 and 12 months post-acute pancreatitis. Thereby, possibly modulating the microbiota could become a therapeutic strategy to mitigate the severity of acute pancreatitis and potentially improve patient outcomes. So in summary, some of the key takeaways is that we have a rising incidence of pediatric AP and CP, mostly because we're also doing formats like these where we're talking more about the topic, and we have a rising recognition about the field in pediatrics. There are significant long-term risks that we need to be aware of: diabetes, chronic pain, EPI, opioid dependence, An early and accurate diagnosis is essential to guide the risk stratification and management. Up to 70% of cases are genetic, especially when we have recurrence. Emerging areas in the field with minimally invasive interventions for complications. We have CFTR modulators, pancreatic enzyme replacement therapy, the effect of the microbiome, all the exciting things that are on the rise for our patients and things that we're looking at. And then future direction was personalized medicine and genetic testing, multi-center studies to refine the risk stratification and optimize pediatric outcomes would be the next steps for us. I want to acknowledge the team at Cincinnati Children's and again CAPER for this wonderful opportunity. Thank you so much, and I'm happy to answer any questions that would come up.
Awesome. Thank you so much for that. We have more and more people coming into the audience, so that's wonderful. And I don't see anything in the chat box, so that's great for me because I have so many questions. But I'll lead with just two things really quickly. And again, if anyone has any questions, please feel free to put them in and I'll read them out. But I guess I'm an adult provider for the most part, and so it's so interesting to hear about the pediatric literature. And one of the things that you talked about with acute pancreatitis is the fluid management strategy. And so I
Mm.
find that really interesting, looking at waterfall and less than 3, and then the pediatric, the liberal group said greater than 1.5. So where are you guys landing in the acute management strategy for those patients? How do you kind of guide recommendations?
So I had to do a lot of math in the background for this, to be quite honest, because there was one was in terms of 1.5 or 3 or 2 times maintenance or more than 1.5 times maintenance. The other one was in ml per kilo per hour. And so what it ended up being is that the 1.5 maintenance is somewhere between 1.5 ml per kilo per hour and 3 ml per kilo per hour. So it kind of falls in the middle section.
Hmm.
And so, what we are doing for our patients and continue to do is starting them at 1.5 times maintenance for the first 24 hours, stretching that a little bit further, maybe a few hours if the patient is continuing to experience pain, and then we drop the fluid rate to maintenance, encourage them to eat, and go from there.
Awesome. And and then one other question I had too, we are doing more and more genetic testing, and I think in the adult world we're, really lagging behind you guys, but we're starting to test people more and more. And I would say, specifically, in the adult world, we have a lot of alcohol-induced pancreatitis, and the more we're seeing young people and testing them, we're finding more of these genetic risk factors that you were alluding
Mhm.
to in the pediatric world. So how do there are certain things like CFTR modulators that we can put people on, and there's, some evidence to support the use there, but there's a lot, to my understanding, of genetic risk variants that we don't really have targeted therapies for. And so how do you counsel patients when they get these results back?
So, quite honestly, some of the patients who come in and end up with these mutations may have had a family history and they understand the course of disease. So, we counsel them just as we would any other patient regarding risk of pancreatic cancer in the future. We need to monitor, your disease course. We have no real way of predicting how things are going to go, but we're going to keep following you every 6 months or so, getting frequent imaging, seeing if there's any ductal changes, if how you do symptomatically, and really take it from there. Because as you said, that some of the mutations are well understood, and there's a lot of what we call variants of unknown significance, which we think are related to the disease course, especially if we don't have any other factors, and a patient who has these recurrent episodes. So we just keep things open with the family. We tell them, there's, depending on how the child is doing at that point in time, we intervene in a way that's necessary. If they need endoscopic therapy or whatnot, then we talk about that. Otherwise, if the child had, 2 episodes but is doing okay, otherwise with no further symptoms, then we just counsel them that there could be some parenchymal changes and what that would cause, in terms of diabetes, exocrine insufficiency, or ductal changes and what that can lead to, and the potential need for endoscopic therapy in the future, and the long-term risk of cancer as well.
Awesome. Thank you so much.
Yeah.
Okay, well, without any other questions right now, we'll switch over to Dr. Brownell. Thank you so much for being here today. And just as by way of introduction, he is hailing from Children's Hospital of Philadelphia, so CHOP. He's the co-director of the Pancreatic Disorders Program, and his clinical and research interests focus on improving nutritional status and quality of life in patients with pancreatic diseases. And on a quick Google, it seems like you did quite a number of fellowships as well, which was super interesting. And I'm sure we're going to learn a lot from this talk. So this is great. Thank you so much for being here.
Thank you, Dr. Lockhurst, for calling me out and for the warm welcome, and to CAPER for the opportunity to present. Really, at some point, you want to go to school all your life, and then your spouse tells you that you actually have to start working, and it all comes crashing down. But yes, so I'm meant to piggyback off of Dr. Saad's excellent talk about, she's introduced essentially, pancreatic inflammation, and then my part is to talk about the consequences of that. So to talk about exocrine insufficiency, diagnosis and management, and then of course, in the spirit of this session, looking forward and seeing what things are on the horizon. And so I have no conflicts of interest. I'm not technically going to discuss off-label use of medications. I'm always looking for more disclosures. So our goal today, at the end, I want everyone to be able to understand the pathophysiology underlying EPI. Want everyone to know how to evaluate for it, and then how to treat it. And I apologize in advance if anyone is eating lunch right now, but you may want to look away from the screen for a second. So for the outline of our talk, what we're actually going to talk about. So first, we're going to review exocrine pancreatic sufficiency and how insufficiency manifests, how we test for it, specifically going to highlight endoscopic pancreatic function tests and MR pancreatic function tests, and then discuss clinical use of these. And I will say up front, and just like Dr. Saad, I am a pediatrician, so this is coming from a pediatric perspective, and I'll try to address the conflicts between adults and pediatrics when I can. So to quickly review pancreatic sufficiency, and so you have exocrine on the left, endocrine on the right. In our exocrine pancreas, we have acinar cells and ductal cells. Acinar cells are where enzymes are made. Ductal cells are responsible for secreting bicarbonate, sodium, and water, which make up together all the pancreatic juice. And then the endocrine cells secrete some hormones. I'm sure they're important for some things, but not for today's talk. So this is a relatively older slide, but I actually really like it because it breaks down the actual percentages of the pancreatic enzymes that are made in the acinar cells. So everyone thinks there's always such an emphasis on fat and on lipase and lipases, partially probably because it's one of the things we're evaluating for pancreatitis. But also, as we'll see over the next few slides, it's because fat malabsorption is what gives you the largest consequence, apparent consequence of EPI. So 90% of what your pancreatic enzymes are made of are actually proteases that are meant to break down protein. Small percentage are amylases, and then the smallest percentage are actually the lipases responsible for digesting fat. So there are two main hormones that are regulating pancreatic secretion. So the first, in response to acid in the duodenum, secretin is released, or is secreted by the S cells in the duodenum. Has multiple functions locally, a bunch systematically as well, but what we're concerned about is increasing the duodenal pH, stimulating bicarbonate and sodium secretion from the ductal cells and the Brunner's glands in the duodenum, and then inhibiting acid secretion in the stomach. Going to stimulate bile production and insulin secretion as well. So secretin, the most logically named hormone responsible for the secretions. The other one involved in pancreatic secretion is CCK, cholecystokinin, famously responsible for contracting the gallbladder and releasing bile acids. But in the pancreas, it's what actually stimulates the proenzyme granules to be released from the acinar cells. Also slows down gastric emptying. Bile release, obviously, is the famous one. And so essentially, these two hormones are working together to regulate pancreatic secretion. CCK is the acinar cells, secretin is the ductal cells. As you know, the enzymes, once they're released, are activated in the duodenum. So you have to have intact brush border and enterokinase in order for these enzymes to be activated early, or to be activated appropriately. There's a number of compensatory mechanisms that keep these enzymes from being activated early, which, as you can see, those are a lot of the same genes and gene products that Dr. Saad referenced in her talk. So then, of course, once you have secreted your enzymes and your pancreatic juices, you digest triglycerides, hydrolyze them. Those free fatty acids are emulsified with bile and acids, and then absorbed into the epithelial cells and exported eventually into the lacteals. So, important component of digestion. So what happens when you don't have adequate pancreatic function? Well, mentioned earlier that fat malabsorption is kind of your biggest consequence of EPI, and part of that is because there's a number of compensatory mechanisms. So gastric pepsin is actually a quite potent peptidase. You have salivary amylase, as something we deal with in pediatrics a lot are kids who get food impactions with carbohydrate-based things. Fortunately, those dissolve over time, and we don't end up having to scope them. And what happens though when your lipase is not being secreted by the pancreas? So you may have heard of gastric lipase and lingual lipase, and question is whether those actually can compensate. So lingual lipase, targets short chain fatty acids, which is a relatively minimal part of our diet, active in acidic pHs. And the only problem with them is that there's not actually any evidence in using modern techniques that lingual lipase actually exists in humans. We have the same genes that rats have for theirs, but it seems to be secreted in the stomach in us. So lingual lipase is off the table. Then gastric lipase we have, which targets short and medium chain fatty acids, so a slightly larger proportion of our overall dietary fat intake. Active at a low pH, so that's great. In the stomach, that makes sense. The problem is pancreatic lipase is the only one that's really going to be targeting all of those longer chain and very long chain fatty acids that are in our diet that make up a greater proportion. As you know, also active at a higher pH. So why is it that gastric lipase, in addition to not necessarily binding preferentially the longer triglycerides, it's also not as efficient. So gastric lipase only cleaves off a single free fatty acid, leaving a diacylglycerol, as opposed to pancreatic lipase, which leaves you with 2 free fatty acids for absorption and 1 monoacylglycerol. So just not as efficient, even if it is helping a little bit. So I've learned from giving various versions of this talk to colleagues, trainees, other people, the public, that once I mention this website, their phone starts to show it to them on whatever the preferred social media app is. So I will just say that AbbVie has put this site out, and I'm not going to say the name of it, but you may have seen these billboards, you may have seen an ad. I apologize if you are about to see an ad, encouraging the general public to investigate exocrine pancreatic insufficiency, as it could be the cause of some of their nagging symptoms. So what are those symptoms? They're generally quite nonspecific. So steatorrhea, obviously the red flag symptom. Frequent stools after meals or snacks, like a strong gastrocolic reflex. Foul-smelling stools, flatulence, abdominal pain associated with eating, voracious appetite, and then one that I have not seen outside of cystic fibrosis is rectal prolapse. You may notice there's a famous one that is both on this website and cited a lot that I didn't include, and that is stools that float. If you ever want a really entertaining read, this paper got an Ig Nobel Prize. But essentially, Dr. Levitt showed that it's not actually fat in stool that makes it float, it's air or gas. So floating stools, not necessarily steatorrhea, just one of my little soapboxes. Look up that study, it's great. So back to our symptoms of EPI. In patients with longer standing EPI, they can start to develop symptoms associated with the malnutrition that comes along with EPI. So these are specific to either macronutrients, so losing energy, you're not going to gain weight as well. If you're a child, if you're more fully grown, you may lose weight. Children also will have suboptimal linear growth. You can also get symptoms associated with fat-soluble vitamin deficiencies. Probably one of the more common ones is easy bruising, easy bleeding, or prolonged bleeding if you are vitamin K deficient. Longer standing deficiencies, so poor night vision and vitamin A, decreased proprioception, and vitamin E, and paresthesias as well. And then decreased bone density, we always think about vitamin D, but actually vitamin K is very important for maintaining bone health. So there are actually case reports of vitamin B12 deficiency as well, and the associated anemia, neurological defects that can go along with that. And essential fatty acid deficiency can cause rashes, poor hair growth. In kids especially, these are the kids who never need to get their hair cut because their hair is just not growing. So how do we diagnose EPI? Well, there's two different types of tests, indirect and direct. Each have their pluses and minuses. The ones that we'll run through quick today, there's the dryling tube method under the direct test, which fortunately is not really done anymore, but we'll talk about briefly. More common these days is endoscopic pancreatic function testing, or a secretin stimulated MRCP. Your indirect tests are not actually measuring the pancreatic function itself, but usually a surrogate marker for it. So there's stool tests looking at all sorts of different potential markers that are indicating whether someone's pancreas is working or not. There's also a mixed triglyceride breath test and a blood test as well for malabsorption. Those last two are not available for clinical use in the United States, but are available under research protocols. So elastase is the famous one that everybody knows about, and probably everybody sends for evaluating EPI. So what is it? It's a protease, so one of those 90% of your pancreatic secretions that is not broken down in the intestine on the way through. So our current tests do not actually detect they only detect human elastase. So if someone is on enzymes, it's not going to affect the test at all. A question that seems to come up a lot. And then there's this traditional cutoff of 200 micrograms per gram of stool. If it's less than that, it is low. I'm one of those people who always wonders where these cutoffs come from and why we do what we do. And this is actually based on a single study of 28 pediatric patients who had cystic fibrosis that were arbitrarily divided into mild, moderate, severe EPI. And they evaluated them with stool elastase, how much fat was actually in the stool, and then the direct testing with the dryling tube method. And so that's the historical cutoff. We, in the pancreas world, I think, who look at elastase a lot more frequently, are kind of have a wider range. Essentially, so we have this pathway here that essentially tells people how to evaluate EPI and dose enzymes. And we actually have a more liberal cutoff, mainly because we want these patients to be seen by GI and perhaps evaluated by a pancreas person before going down a diagnostic odyssey that may not be helpful. But in general, 200 micrograms per gram is the cutoff for normal versus abnormal. And so I wanted to see if this was valid externally outside of CF, because again, I'm one of those people. And this was a graph from the original study of the patients with CF. And then this is just a cohort of patients I had in a study with chronic pancreatitis. And so, yeah, it lined up almost perfectly. So I've begrudgingly accepted elastase as an appropriate surrogate. So pros, it's very inexpensive these days. It only requires a single gram of stool. And it's not affected by diet like fat intake, whether someone's fasting. It is not the most convenient thing. There's variability among assays. Also a stool test. Getting teenagers to collect stool is one of the more difficult things in modern medicine that I deal with. Another big problem with it is it's a concentration micrograms per gram of stool. And so if your stool is very dilute and watery, then your elastase is going to appear low, even if the pancreas is working fine. So the gold standard, annoyingly, for EPI is the coefficient of fat absorption. So you may have heard of the Creon formulation changing a couple of years ago, or some of these newer enzyme preparations that are being tested, like edrylipase. And the FDA requires that you demonstrate changes in the coefficient of fat absorption as the primary outcome in order to get a pancreatic enzyme product approved on the market. So CFA for short is very annoying. Whereas with elastase, you only need a gram of stool. For a CFA, you actually need 72 hours of stool collection. You also need to know what they were eating that then produced that stool, which, as we all know, everyone's intestinal transit varies from person to person. The normal range for adults, really anyone greater than 6 months of age, is that you absorb 93% of the fat that you take in. Less than that, you absorb slightly less. This test, as I've kind of already alluded to, is pretty labor intensive, difficult to obtain. So it's debatable, but historically patients needed a diet high in fat in order for it to be accurate. This hasn't really been borne out in more modern methods. The biggest problem I see, though, is it's not just EPI that's going to cause you to have dietary fat malabsorption. You can have fat malabsorption if you have any sort of defect in your bile acid circulation. If you have damage to your mucosal surface, you're going to have dietary fat malabsorption. So, not the best study to be specific for the pancreas. So this is where I kind of pause and say, like, I keep referring to EPI, and I've talked about the symptoms and how we're testing for it, but we haven't actually defined it. And so this is where I pose to you, like, how do you think about it? Is it an elastase that's less than 200 micrograms per gram of stool? What about the other enzymes? So you can have an isolated lipase lipase deficiency. You can have, specific enzyme deficiencies themselves. Is it inadequate bicarbonate secretion by the pancreas? So if your ductal cells are not secreting bicarbonate, even if you're making enough enzyme, you're not neutralizing your stomach acid, and those enzymes are going to be denatured and then not work. Is EPI defined by the symptoms of malabsorption, like steatorrhea? So it's kind of tricky, and if you have been to Pancreas Fest before, you may have heard Dr. Saad's colleague, Dr. Trout, the radiologist, very lovingly berate us for not giving him a specific definition for EPI so that he can then diagnose it with radiographic testing. But I always think of Judge Potter Stewart's ruling on something that I can't really share in public, but the question was like, how do you know what this is? And he says, well, I know it when I see it. So we all guess know EPI when we see it. And so the best definition I've seen from Dr. Forsmark is insufficient pancreatic secretion resulting in malabsorption. General, but telling you exactly what's happening. We don't really have any clear criteria for it. Also, we think about it as a binary variable, whether your elastase is above 200 or below 200. The reality is it's a spectrum, and symptoms may pop up at different degrees of pancreatic function. So, if you still have a lot of pancreatic function remaining, your tests are going to be normal. You're not going to have any symptoms. But then as your pancreatic function starts to drop off, you might develop symptoms. And then finally, the test will catch up. And one of the big problems, especially in chronic pancreatitis, is that that's not reversible. Like, by the time you've detected EPI, it's already too late. And so that's a huge area of interest that we'll talk about shortly. So I've mentioned the dryling tube a few times, and I clearly say I'm thankful that it's not done, but essentially you put an NG tube down to suction, and then you put an ND tube down the other nostril, leave them both there, give someone secretin, and then you just blindly sample the fluid over an hour, 2 hours, sometimes 6 hours. So it was not great in kids to keep them still for that long. Also exposing them to radiation while you're placing the ND tube, and not comfortable to have barrels coming out of each nose. So not really done anymore. So in pediatrics, we actually pretty commonly will use endoscopic pancreatic function testing in some specific situations. So specifically, this is helping you evaluate acinar function and detect some specific deficiencies. The indications in pediatrics, at least, are to evaluate for EPI, define the extent of pancreatic function, rule out CP and when it's otherwise inconclusive, or to clarify the cause of fat malabsorption. And I will say, honestly, we at our institution tend to use it more to prove that someone doesn't have EPI rather than just getting it at when the pretest probability is high. It's not necessarily needed to confirm the diagnosis, but really more to show, to figure out what else is going on. One of the big drawbacks for endoscopic pancreatic function testing, and why one reason it's not really used that much in adults these days, is there's not a lot of agreement on a protocol. So NASPGHAN, our pediatric international PGI group, has put out a suggested protocol, which is here on the right, essentially giving CCK or secretin and then sampling at very specific time points, sampling the same enzymes. And so essentially what you do is, what we actually give both secretin and CCK, going off the principle that you're evaluating both acinar and ductal function. In the literature from the early 2000s, the aughts, there was a paper that showed that CCK and secretin were more or less interchangeable. But again, that was not a protocol that is in use currently, and so it's hard to know how valid that is. But essentially, we will give the medications and evaluate samples, essentially at time point 0, 5, 10, 15 minutes, and evaluate enzymes, pH, essentially to validate, whether your enzyme activity is going to be there or not. If it's acidic, obviously you can expect reduced enzyme activities from them being denatured. And then measuring bicarbonate as well for ductal function in some cases. And so, again, used more often in pediatrics than in the adult world. So the other thing that's more or less standard of care these days for evaluating ductal function is an MRCP with secretin. And so essentially you try to quantify the amount of fluid that's secreted after you give secretin while someone is still in the scanner. A bonus benefit of it is you can actually get really good information about the ductal anatomy. Once the duct fills with fluid, that shows up really nice on a T2 sequence. And so you can see here immediately after secretin, don't have much of a response, but within 10 minutes, you can see the duodenum all the way over to the jejunum light up with fluid that's been secreted by the pancreas. There's a lot of work going on right now to quantify it using AI, actually. So this is probably going to be a pretty useful test going forward. So the two indications then are to evaluate for EPI as well as pancreatic anatomy. So I want to talk about the malabsorption blood test, since one of the focuses of this session is looking to the future. So this is a test that's used in research, validated in multiple different conditions, not FDA approved just yet for clinical use, but is on the way. And so essentially this is based on the principle that free fatty acids and triglycerides will differ in their rate of absorption. So whereas free fatty acids are just rapidly absorbed, triglycerides have to be hydrolyzed first by lipase. And as we talked about earlier, the longer chain ones especially need that pancreatic lipase present in the duodenum to work. And so essentially the test uses odd chain fatty acids just because they're relatively low concentrations. Right now, using a 15 carbon length free fatty acid and then a 17 carbon length triglyceride, the PA, the pentadecanoic acid, is going to be rapidly absorbed, and then THA needs lipase, so it's going to have a slower absorption. And so these are some, from a study, these are some healthy volunteers. The darker line is the PA, the free fatty acid. The lighter line is the triglyceride. And so occasionally you can see how the triglyceride lags behind a little bit, but essentially their absorption matches in someone with a healthy pancreas. In patients who have chronic pancreatitis and EPI, you can see that the relative absorption differs significantly, whereas the free fatty acid is, readily absorbed in curves that look similar to the healthy people. There's next to no absorption of the constituent free fatty acid from the triglyceride because the hydrolysis hasn't happened. So what's next once you've diagnosed EPI? So right now with an elastase, God forbid, a 72-hour fecal fat and coefficient of fat absorption, how do you actually treat it? So we'll go through this relatively quickly. But essentially, you replace the enzymes. Pancreatic enzyme replacement therapy, you give people the enzymes that their pancreas is not making. This is the standard of care. So there's two different ways to dose pancreatic enzyme replacement therapy, or PERT, either based on the patient's weight or based on the amount of fat they consume. There's pluses and minuses to each. It's kind of easier to do weight-based in a otherwise healthy person who takes all their food by mouth. You just say, all right, you weigh this much, take this amount at every meal, this amount at every snack, and then, kind of adjust based on symptoms. Fat-based is used more in infants or people who are on enteral feeds where you know exactly what their fat intake is. Also, if you are not getting the response you are expecting to weight-based dosing, you may try to calculate the fat-based, and I will show you an example of that in a second. But I will again refer you to the clinical pathway that our group has put out for dosing in children. Essentially, this is a very small piece of it, but tells you how to start enzymes, how to assess their efficacy, and how to troubleshoot when things aren't going well, when to refer, how to adjust the doses. And so if you are interested at all, there's a QR code here. You can also just Google, CHOP pathway EPI. So just as an example of, the differences between weight-based and fat-based dosing. So you may say, all right, at a meal, have, 2 capsules of Zenpep, 3 capsules of Zenpep based on your weight. And so this is just to show you the differences, the wide difference in fat intake you can have at a single meal. So no one I know in Philadelphia has spaghetti with just sauce. You've got to throw some butter on there too. And then while you're at it, meatballs. And then if you're in Ohio, like Dr. Saad, they put cheese on everything. And so you can see the amount of fat intake rapidly increases. And so you far outpaced your, your enzymes capability, your oral enzyme capability to digest it. And so always something to think about is how much fat your patient is taking in. So the other big thing, that's taking care of the macronutrients, right? Especially fat intake. And so the other thing that we monitor are micronutrients. So, I've created this chart over the years, essentially with on the left are the things that we're evaluating, how we're treating them in the middle, and then our frequency over on the right. But essentially, once someone's diagnosed with EPI, you want to get a baseline of, what their essential fatty acid status is and some of these other nutrients as well. Because, some people may have had EPI for a while. The patients that Dr. Saad and I are more likely to encounter are the ones who have not actually had EPI for a while. They're just starting to develop it. And so essentially in those patients, we're getting a baseline, for monitoring going forward. But if you have a patient who's had EPI long-standing, they may be deficient in all these things and may need supplementation. So you provide them supplementation and then, follow up on these things relatively frequently to make sure that they're actually being corrected with supplementation. If they have ongoing fat malabsorption, they're going to have ongoing, fat-soluble vitamin malabsorption as well. So you need to follow it closely. I kind of referred to the troubleshooting earlier, but there's, studies that show, if you take your enzymes, so in kids, kids who are picky and their meals drag on and on, often we are telling them to have, split their dose, have some at the beginning and some halfway through, probably about 20 to 30 minutes in after the episode of Bluey is over. So that's the strategy we often have to employ when the enzymes don't seem to be working. But there's, plenty of other things that can affect it as well. So they're temperature sensitive. In the summertime, they're either left out on the dashboard or they were in the cooler on the beach, no in between. But both of those would deactivate enzymes. Sometimes changing the brands. If they were shipped via UPS and sat out in the truck for a long time. But essentially we can adjust the dose, again, looking at their actual dietary intake, but then it is always good to take a step back and say, all right, does this patient actually have EPI? Was their elastase actually low? Do they have an endoscopic pancreatic function test to actually confirm this is what was going on, or did we look for other mucosal causes? And one thing to always think about too is the quality of life piece, because often my colleagues will say, what's the big deal if they do just have IBS and we're giving them enzymes and they're feeling better? You take these enzymes before meals and snacks, and for kids, that means at school they have to go to the nurse's office. They're different from other kids. And so quality of life is a pretty big piece of it, and you want to balance how well you're addressing someone's symptoms versus the burden you're putting them on. And so what's the future of EPI going forward? What are the emerging things? So definitely earlier detection, as I got to alluded to before, especially in chronic pancreatitis or pancreatic cancer. Once you've gotten EPI, it's too late. Or like a clinically apparent EPI, it's too late. So if you can diagnose it early on, then you can actually make changes before someone becomes malnourished. Also better testing. This is where I hold out a lot of hope for the malabsorption blood test actually being useful. And then better enzymes. So I kind of alluded to the pill burden a minute ago. Some patients can take up to over 40 capsules a day. Another problem is the current preparations are all pig derived from pig pancreas. And so that's not halal for patients who have that requirement. And there's plenty of people who, have dietary restrictions otherwise where they can't have meat products. And so that is not sensitive to them. There was a product I mentioned earlier, edrolipase, which was a yeast-derived pancreatic enzyme preparation, but unfortunately, it never has not made it past phase 2 trials. Not only is it essentially have the same adverse event rate as the porcine products, but it doesn't work as well. Whereas the typical enzymes increase your coefficient of fat absorption to the high 80s, still not normal. Edrolipase never made it past the 60s. So thank all my colleagues in the Pancreas program here. And if you need to get in touch with me, I welcome it. You can contact me here. Thank you.
Awesome. Thank you so much. That was wonderful. You somehow made me pay attention through the basic science portion more than I think I've ever paid attention before. So that was great.
Awesome.
And there is a question in the chat. I think you touched on it a little bit, but I'll give you a little time to answer as well. But the question essentially is there a role of PERT in acute, recurrent, and chronic? I think the answer is yes, but we'll let you just kind of summarize maybe very quickly.
Yeah,
And then I have a question for you
Dr.
as well.
Saad had brought that up. So our Inspire Consortium, our international study group for pediatric pancreatitis, retrospectively has shown that patients who were prescribed enzymes, honestly, regardless of their genetic variants, had less frequent episodes of pancreatitis. The only prospective studies looking at enzymes are looking at uncoated enzymes, so essentially Viocase, which is the tablet that you crush up and add to tube feeds, or use to unclog G tubes if you're on call in the hospital in the middle of the night. There have been studies, 2 studies from the 80s that showed that using that enzyme preparation was associated with decreased pain in pancreatitis. That hasn't been borne out with the more modern enteric-coated enzyme preparations. Dr. Saad, feel free to add anything else if I left anything out.
I think you've covered everything that I would have said. Naylor, thank you for answering that.
And then I'll just sneak one more question really quickly. So obviously we use a lot of formulations of PERT in the adult world as well. And something we're seeing more and more is an issue with compliance. And in kids, young kids whose parents are probably giving them the medications or they have to go to the school nurse or things like that, there's one thing, but what about like teenagers and older kids? And what do you guys encounter and what are strategies to deal with that?
So, in the kids who truly have EPI, we, both of us have relatively significant, populations of the the ones that people we learned about in med school and on boards, like Shrockman-Diamond syndrome and Johansson-Blizzard, the kids who truly have EPI or, post EPIT where they've had their pancreas taken out. Honestly, I don't see adherence being as big of an issue because they really get the effects of not taking their enzymes, of having cramping and pain. And I've yet to meet a teenage boy who doesn't want to be taller, and so a lot of them actually, it's not as big of an issue. That where it comes into being a problem is taking medication at school being different from other kids. But fortunately, these days with social media, honestly, I feel like there's, plenty of people. The NPF, National Pancreas Foundation, actually has, they've recently hired a young person to run their social media stuff or to help participate in that, and has done a great job of, normalizing that for kids. And so really, it's not as often an issue of adherence, so much as it's more of a problem with administration, like I encountered a father of a patient who was meeting for the first time, whereas I'd seen the mother before, and he thought you're supposed to give the enzymes after meals, and so I don't think adherence is as big of a problem just in my practice. I don't know if Dr. Saad has any different thoughts, but I actually haven't encountered that as much.
Yeah, I think in general, I agree with you. There's definitely, the TPIT population, the patients who are severely affected by this do a really good job at actually taking their medicines, even 14 and after, they're doing it themselves without reminders from parents or whatnot. But now talking about it, there's definitely a couple patients that I need to follow up on that I feel have been lost
Yeah.
in this process. So maybe, there's definitely a percentage, but it's not as prevalent, I would say, as it is in adults in terms of non-compliance, at
Yeah.
least from my limited experience so far as an attending.
And I think where you'd be more likely to see it is like and where I guess I have seen it more now that I think about it, are the ones who are taking enzymes in an effort to try and, space out the lengths of healthy time between episodes of recurrent pancreatitis because, they feel fine anyway. And, they're not going to have any sort of dose effect that, is readily apparent from day to day. And, they're kind of in that category of taking a medication for like more of an abstract reason than a concrete reason. And, teenagers are not great at abstract thought. So,
Yeah, neither are
that's where it
adults. Maybe I'll try telling my adult patients they might get taller if they take it. We'll see what happens. Awesome. Well, thank you both so much. This was great. Oh, no, I just don't know how to use this, so I'll say that we answered it. But thank you guys again. This was really wonderful, and I really appreciate you guys taking the time and being here today.
Thank you.
Awesome.
Thanks,
Thank
everyone.
you so
Thanks
much for the
this
invitation.